Hi, yeah, can everybody hear me?
Yes.
Yes.
Okay, great.
Okay.
You
So
need to speak
welcome.
louder, doctor.
Well, can you turn your sound up a little bit, Dr.
No,
Morgan?
mine is to the top.
I'm gonna mute everybody, and then Dr. Morgan, if you can just press your unmute button. I'm gonna mute all the guests so that there's no other sounds, okay?
Okay.
Okay. And then Dr. Morgan, you can unmute yourself and you'll be the speaker and I'll introduce you.
Okay, great.
You're still a little soft. Is there any way we can get you any louder?
Sure, I can speak up.
Okay. Okay. Welcome. You can see we have a lively group here. This is the Live Well Senior Program, and Dr. Morgan is a first-time presenter for us. And although he's not new to his specialty, it's our first time hearing from Dr. Morgan, who is an orthopedic surgeon. And as you know, he's going to be speaking about shoulder pain today. And Dr. Morgan, I would love it if you would introduce yourself, please.
Okay, sure. So my name is Dr. Morgan. I'm an orthopedic surgeon. I specialize mostly in shoulder and knee problems. I did my medical school, University of Minnesota, where I grew up, and then did a residency in Maryland, and then came out to LA to do a fellowship in sports medicine. And a fellowship is an extra year of training after residency to really focus on a subspecialty within orthopedics. And so I chose sports medicine, which is mostly arthroscopy, which is minimally invasive surgery of the shoulder and knee and elbow. And so I was in practice in Minnesota for about 6 years before moving back to LA. And I've been here for about a year now. And so I have an office in Glendale. I'm affiliated with Glendale Adventist. And so we see patients of pretty much all ages. And so, yeah, that's a little bit about me. We're going to be talking about some shoulder pain today. And I do have a short PowerPoint that I wanted to show just to get the thing started, and then we'll open it up for questions at the end. Is there anything else you wanted to mention before we get started?
No, I just want to say welcome to you. And I know that everyone's very excited to hear what you have to say because shoulder pain is very common in this population. And so is knee pain and hip.
Yeah, we see it all.
So thank you so much for agreeing to do this for us today. We really appreciate it.
Yeah. All right. So I'm going to go ahead, share my screen, and get this talk started. All right. Well, as we discussed, shoulder pain is very common. Millions of Americans deal with shoulder pain on a yearly basis. It accounts for many visits to our orthopedic offices. The outline of today's talk, we're going to talk a little bit about the anatomy. We're going to do a little teaching here so everybody can impress their friends with their knowledge of the anatomy of the shoulder. And then we're going to talk about the common causes of shoulder pain. We're going to talk about the rotator cuff. Very common reason, number one reason that people come to me for shoulder pain is their rotator cuff problems. And those problems can vary from a tear to tendinitis, and we'll get into the differences of what that means. Other common causes are biceps pain and labral tearing, and we'll get into what that means, and shoulder arthritis. So osteoarthritis is the wear and tear type arthritis that we see more commonly in the knee and hip, but can be present in the shoulder as well. And then adhesive capsulitis, that's the fancy term for frozen shoulder. So some folks get that where the shoulder is stuck and doesn't move and becomes very painful. And we'll talk about what that means. And we'll go over a little bit of the diagnosis. Again, just learning a little bit about how these different pains can present and some differences between the two, so you can try to get an idea of how we distinguish one problem from another, and then talk about treatment. How do we get patients better and back to enjoying their life? Because that's really why we're here and why we do what we do. So to start with the anatomy, are you guys able to see my cursor as I move it around, my mouse? Well,
Yeah.
the shoulder is
Yes, yes.
is a ball and a socket joint. So this is the ball or top of the humerus or arm bone, and then the socket is part of the shoulder blade or the scapula. And the bones at the joint are covered with this cartilage coating. And so that makes the joints move nice and smoothly. When that cartilage wears out, that's what arthritis is. And you've heard the term bone on bone. So when you lose the cartilage on this side of the joint and this side of the joint, and those two bones are rubbing and touching, that's arthritis. So around the socket is a structure called the labrum. It's a cartilage ring. It's like a washer or gasket. And so it helps to deepen the socket and provides the attachment for the ligaments which hold the joint together. So sometimes people have injuries to that and creates pain deep in the shoulder. So that's just another picture of it here down on the bottom showing the labrum and all the ligaments attaching to it. So here is the shoulder with now the muscles added to it. So in the very front is one of the rotator cuff tendons. So we've got 4 rotator cuff muscles, and the tendons are this white part here that attach the muscle to the bone. So the rotator cuff is 4 tendons that goes from front to back around the top of the shoulder, and then the biceps tendon coming up the arm here. And here's the back of the shoulder. So now it's like we're looking at the back of the shoulder, and you can see the rotator cuff tendons. Here's 1, 2, 3 that we can see from the top to the back. Okay. Between the rotator cuff and the top of the shoulder blade is this little blue tissue here. It's called a bursa. And that's something that can get inflamed and cause people to have shoulder pain. So if you've heard the term bursitis, that's what that is. That's inflammation of that bursa, that little sac that lives in there to protect this tendon from rubbing on the bone. So here's a picture from an article from 1992 where they took the whole rotator cuff off the bone. And I like this picture because you can see it really is like a cuff of tissue. It's all one continuous thing. So it really is kind of like the cuff of a shirt. It goes all the way around the top of the arm bone to move the shoulder. So when you have rotator cuff disease, and I use that term to include tears versus inflammation. So if you have a tear, you've actually torn one of these tendons off of the bone. And it can be 1 tendon, 2 or 3. Pretty rarely do we ever see all 4 detached, but I guess that could happen from a big injury. But the tendon tears right off the bone. When it's more tendinitis or inflammation, the tendon is intact. It's not torn, but it's just inflamed. It creates pain. So where you get the pain for both of these problems can be around the front part of your shoulder. So in the front and to the side, kind of right off the side of the shoulder, people often point to that area just below their shoulder on the side of their arm. And then it radiates down to the mid part of that arm. And people complain of nighttime pain. Wakes them up at night when they try to roll around, can't get comfortable. Or they'll complain of weakness. They can't lift up overhead. They feel weak. They can't really lift like they used to. And it'll often be worse with the overhead activities or reaching behind the back, reaching into the back seat of the car or reaching up to try to fasten the bra. A lot of females have complained of that. They can't do that anymore because of the pain and the loss of motion. And then sometimes it'll radiate up into the neck. That muscle called the trapezius is what attaches from the neck down to the shoulder. And so that'll often become painful as well. So on the exam, when we're in the office, we do these different range of motion tests to check people's motion. And if they start to lose their range of motion, then we start to worry about their tears. If they lose their active motion, meaning they can't physically lift their arm up overhead, that means they could have a torn muscle or rotator cuff. And they can't lift their arm up anymore. So there's these different tests that we do to check strength and motion. And so I've listed that there. And so here's what we do when we're trying to figure out what's going on. We always get x-rays to start because we want to make sure people don't have arthritis or some other problem going on. And typically the x-rays in somebody who has a rotator cuff tear are going to be normal because it's not a bone problem. It's a problem with the rotator cuff tendon, and that does not show up on an x-ray. So then we do an MRI, and I've included a picture of the MRI here. So this is like we're looking at the shoulder straight on from the front. Here's the ball. Here's the socket. Here's the rotator cuff tendon, this little black thing here. This rotator cuff tendon is supposed to be attached over here on the side, the top of the ball, but it's been torn and it's retracted back there. So because the rotator cuff is under tension, when they tear, they kind of slingshot or retract, pull away from the bone. And so, that is something that's not going to fix itself. It's not going to just magically make its way back over here and reattach itself to the bone. So that's why the MRI scan is important. That's how we diagnose a rotator cuff tear versus just inflammation. So if we look at how many people have these rotator cuff tears, I want to highlight this line here. 54% of those over 60 had a tear. So they took MRI scans of 96 people that had no symptoms whatsoever, and half of those people had a tear. So, half of folks over 60 are walking around with a rotator cuff tear, and they don't even really know it. And there's partial tears where only part of it tears off of the bone. And sometimes these partial tears will go on to become full tears where it's completely torn off the bone. And again, age over 66 with pain on one side, there's a greater than 50% chance that they have tears on both sides. That's how common rotator cuff tears are. Now, why is it that they're so common? It's because little evidence shows that any spontaneous healing can take place in these rotator cuff tears. There's just not very good blood flow to that area. So, if you cut your skin, it bleeds and then it heals. When you break a bone, it bleeds, it heals. If you tear your rotator cuff, it doesn't bleed. There's very poor blood flow, so it just can't heal. So it just stays torn. So what do we do for non-operative treatment? So the American Academy of Orthopedic Surgeons puts out these guidelines, and they say the first thing we want to do is start with NSAIDs or anti-inflammatory medications like Aleve, ibuprofen, Motrin. So for folks who can take those, we recommend that to reduce pain and inflammation as a first step. Then once we get the inflammation down, we start some physical therapy. And the therapist's job is to reduce the inflammation, start with range of motion, stretching, strengthening exercises. They also do ultrasound, electrical stim, all these other things to try to reduce pain and inflammation. Another thing that we can do that we haven't listed here is a cortisone injection. And we'll talk a little bit more about that going forward, but cortisone can be helpful to reduce inflammation in the joint, but it's not going to fix any of the torn tendons. It's not going to reverse the arthritis that's there, but it reduces pain and inflammation. It's a temporary thing, can help reduce the pain for a few months, but then the pain will likely come back. So if we're talking about surgery, so say somebody has a tear, complete tear off of the bone, doesn't get better with the physical therapy, medications, injections, then we'll do a rotator cuff repair. And we do it arthroscopically. That means with the camera. So this is a picture of what it looks like with the camera after we've repaired it. So this little white here is the tendon, the yellow is the bone, and this suture are these little sutures stitches that we put across the rotator cuff. And here's a little diagram here with these little anchors, little mini screws. They go into the bone. We pass it up and over the rotator cuff to reattach it back onto the bone. So once we've done that, then it's time to let the body heal. And that tendon to bone healing takes about 3 months, which is why the full recovery is 4 to 6 months. So we got to protect the shoulder, let the tendon heal, then gradually strengthen the muscles back to where you were before your injury or before the tear. So it's a long recovery, but in the end, you know, people do very well from these. They get their motion back, they get their strength back, their pain goes away. So it is a good operation, but it does take a long time, and people have to have a lot of patience to work through physical therapy to get the best result. Sometimes we see these cases where we can't repair it. It's been torn so bad, so big that we actually have to do a reconstruction of the rotator cuff. So this is a picture showing that. We put in a graft to reconstruct the rotator cuff because it's so badly torn. It's retracted, it's scarred in, I can't fix it. So we reconstruct it with this graft. This is a newer surgery that's been done over the last 7 to 10 years to help with that particular problem. And the reason that we do that, the reason that it helps is because it prevents this, which is where the ball slides up out of the socket or superior escape. And when that happens, the ball starts to rub on the top of the shoulder blade, and then you get arthritis. And then it becomes even more of a painful situation. So that's why we like to repair these rotator cuff tears before they become too painful and before they progress to this arthritis problem. Okay. So that was on rotator cuff, and I'm sure we'll be talking more about that when we get to the question and answer section. But I did want to move on to the next common thing, which we see is biceps and labral problems. So the biceps tendon, here is the biceps muscle, here is the tendon. This is called the long head. There's two muscles to the biceps. That's why they call it biceps. The second one they don't show here, but that other muscle attaches over here. But it's this one, this long skinny tendon, that tends to cause problem in people because it comes up between the rotator cuff tendons and actually attaches onto the top of the socket. So here's the biceps tendon attaching on the top of the socket. And so you can have tearing of the labrum, or this cartilage ring where that biceps attaches. And they call that a slap tear. And that creates pain deep in the shoulder. Now, typically this is going to be from somebody who's had an injury. Maybe they fell on their arm outstretched. We see it a lot of times in overhead athletes or throwers or people who are laborers and are working overhead all the time. They tend to get these. And this, people are going to have more pain in the front of the shoulder, whereas rotator cuff tends to be more on the side of the shoulder. And the pain is in the front, and it's deep, and it's worse with overhead activities. And again, we see that in our throwers and laborers, or in people who have had an injury, a trauma, fall onto an outstretched arm. And so the physical exam, people are going to have tenderness over the biceps. They're going to have some of these positive tests that we do to test and stress the arm and reproduce that pain. And that helps us figure out if that is truly the cause of their pain. And then again, we're going to do an MRI, because again, the x-rays are going to be normal in this setting. But the MRI scan is going to show us. So on the left side picture here is the normal MRI with the ball and the socket, and the labrum here is this little black triangle attached to the top of the socket. And on the right here is a labrum tear, the slap tear, where the labrum here is popped off the bone here. And you see this white is the fluid inside the joint. And so you can see that distinction. So that's a tear, and that creates that deep shoulder pain. And so what that looks like in an arthroscopy, when we treat these, so this is the inside of the shoulder joint, here's the biceps tendon, here's the labrum, and we've tacked it down with these little suture anchors to repair that labrum back onto the bone. The other thing that we do to treat this with the surgery is we actually cut the biceps tendon here in the socket and reattach it lower down the arm with a little anchor, and that eliminates the pain. But again, we only go to surgery if we failed all those non-operative treatments like we talked about, physical therapy, anti-inflammatories, maybe an injection of cortisone into that area. And most of the time, people are going to get better with the non-operative treatments and avoid surgery for these problems. So shoulder arthritis. This is the next topic. So shoulder arthritis is also very common, not as anywhere near as common as knee and hip arthritis, but we do see it. And that creates this deep shoulder pain. It's an ache. It's worse after activity. Then they start to get stiffness. Maybe patients will complain of some grinding. Again, it's that bone on bone. So people don't feel that the joint is moving smoothly. It's kind of grinding and catching. And again, it gets worse with activity. The more you use it, the more pain people tend to feel, and they feel better once they've rested it and let the shoulder calm down. So here is what an x-ray looks like in a normal shoulder. Down here, bottom left, again, the ball in the socket with a nice smooth ball shape here and good space between the bones, versus this upper right-hand side with the arthritis. The bones are touching. There's a big bone spur down here on the bottom. There's a little cyst in the bone where the bone is starting to wear away. So that's what arthritis looks like inside a shoulder joint. And again, you lose your range of motion. You get that crepitus or that grinding sensation. People usually have normal strength to their shoulder because they haven't torn any tendons, but they just have pain and loss of motion. So that's something that comes on gradually over time. You know, why do people get that? Well, sometimes it's from a trauma, you know, earlier in life. If you had a shoulder dislocation or shoulder injury when you were younger, you damage the cartilage that coats the bone and then it breaks down over time. Other reasons are genetic. You know, it's just the unfortunate genes that we inherit, and some people's cartilage just isn't as durable as some others. That's why we see people with knee and hip arthritis as well, right? I mean, it's nothing that you did wrong. It's just, you know, that the cartilage just wore out. And that has to do with some genetics and how durable our cartilage is and some of the proteins we have floating around in our joint that help protect it. So for arthritis, again, we're going to start with those non-operative treatments. You know, it's a very common theme, right? Physical therapy, anti-inflammatories, injections. So with these injections, we try to get it in between the ball and socket joint. Because there's arthritis, it's a very narrow, tight space. So sometimes we'll use x-ray or an ultrasound to guide us to make sure we get it in the right exact spot. Injections are a little controversial in the setting of arthritis because if they don't work and people go on to a surgery like we show here, it can increase your risk of an infection. So, you know, we have to be very selective when we do injections. We just don't want to do them, overprescribe them. We're very selective in how often we give those. We counsel the patients about what that might mean for future surgery. So the top, let's start on the bottom. So the bottom is a standard shoulder replacement. The ball gets removed. It gets replaced with this metal ball with the stem that goes in the center of the bone. And then there's a plastic socket that gets cemented into the original socket. So that's a total shoulder replacement. Then there's something called a reverse, where you do the reverse of a normal shoulder. So you put a ball where the socket used to be, and you put a socket where the ball used to be. And the reason we do that is for people who have that problem with the rotator cuff tear, who then developed arthritis. So this is called a reverse total shoulder replacement. And the reason you do that is that by switching the orientation of the joint, it improves the mechanics and allows the outside muscle, the deltoid muscle, to do the work to get the arm up overhead. Because the rotator cuff is torn, people can't lift their arm up overhead. So you do this, it improves the mechanics, allows the deltoid, the big muscle on the outside, to lift the arm up overhead, and then people can have improved function and their pain from their arthritis is gone. So the last topic is frozen shoulder. You may have heard about this. This is where the shoulder gets very stiff. And there's three phases to this. So there's the freezing phase, where there's lots of inflammation. There's just pain, and then people lose their range of motion. Then there's the frozen phase, where the pain subsides, but now the shoulder is stuck. I mean, you can't really move it very much, but the pain has come down. And then there's the thawing phase, where the body finally releases this scar tissue and this inflammation, and then the range of motion comes back. And we don't know why people get this. but we know that it's more common in folks with diabetes and thyroid disease. So those are most of the patients that we see are that with the frozen shoulder are diabetics. Now, sometimes it can happen from a trauma. Sometimes it comes out of nowhere and we really don't have an explanation at all. But what it is an inflammation of those ligaments. So here's the picture of these ligaments that are holding the joint together. These get really thickened and inflamed and cause the shoulder to be immobile because the ligaments that hold the joint together are just so thick and inflamed that you just can't move. It takes 2 years for this to go away. If you leave it alone and do nothing, it'll get better on its own in about 2 years. But here's what it looks like on the inside of the joint. So this is, again, during an arthroscopy where I have the camera inside the joint. And just see, look how red this is. This is all inflammation of that joint lining. So this joint is very angry. And these ligaments are very thick. And so you just can't move the shoulder at all. And that's what it looks like on the inside. And so in patients with frozen shoulder, they've lost their active and passive range of motion. That means actively, they can't move it on their own. Passively, if someone else tries to move it for them, it can't move. And they're pain at the extremes of the motion. So you might be able to move, a little bit, but as soon as you get to the end of where it's comfortable, or where you can move it, it's going to start hurting and create that pain. And again, strength is intact because nothing's been torn. It's just a very strong inflammatory problem inside the shoulder. And so again, we're going to do the anti-inflammatories, physical therapy. In this case, we're going to recommend injections of cortisone into the joint. It's particularly helpful in that early phase, that inflammatory phase, before you lost all your range of motion. If we can get to it and get the inflammation down, we may be able to prevent it from getting worse. So I typically recommend to my patients that after we do this injection, we get them into physical therapy and then have them continue physical therapy 3 times a week to really make sure we're getting good range of motion and stretching so that the range of motion doesn't, we don't lose that range of motion again. And if we do go to surgery, then we go in arthroscopically and actually release those ligaments. We cut them and we release and remove all that inflammation tissue, and then we manipulate or move the shoulder while somebody's asleep until they have full range of motion, and then we send them home and immediately have them go to physical therapy. So that's all I had for a PowerPoint. I just wanted to highlight some of the most common things that I see in the office and highlight those for you. So if you ever yourself or somebody you know is starting to have some shoulder pain, you might have a little insight as to what might be going on and how to give them some advice or direction of where to go. And here's my information. So I'm here in Glendale. Again, I'm part of Adventist Health with Glendale Orthopedics. My practice is with Dr. Sepkinian, who is well known to the community. He does mostly joint replacements of the hip and knee. And we are at Eulalia Street, which is just off Brand by Glendale Memorial. And that's our number there. So I'll leave that up for another minute in case you want to jot down any of that information. And then I can switch it over so I can look at the chat and see what questions people might have.
Thank you, Dr. Morgan. That was excellent. I really appreciate you putting all of your contact details here so everybody can get that. Are you okay with using the recording part of it to share with our viewers again, or not? Or you can email me if you're not comfortable with that.
With what?
Well, I'd like to be able to share the video portion if I can, but we can chat about that later. That's anyway, if it's up to you whether or not. I usually always ask for permission to use the video for the Live Well Senior Program, so people can view it again if they need to.
Yeah, of course. It's a good reference to have, just to be able to look back at that. And I know it was a lot of information. I mean, I live and breathe this stuff every day, so it's pretty routine to me, but it's all new to my patients and to most folks out there. So good to have that as a resource. So I'm looking at the chat. I don't see any questions that have popped up as of yet.
Dr. Morgan, can we ask a question of you?
Yes, you can, but we would prefer that you use the chat feature. If you don't know how to do that, then you're welcome to. It doesn't seem like anybody else is asking anything yet. So who is chatting right now?
That's
Well,
Elena.
I did see one question just pop up. So it says, what are the pros and cons of reversing the ball and socket? So the pro is that that's the preferred shoulder replacement option when people have a rotator cuff tear and arthritis. And so it's something that became more popular over the last 20, 25 years as a way to treat this problem, where before we didn't have any surgical treatment for it. The cons of doing that is that it's kind of the last operation that you can have. If that doesn't work or it develops a problem, there's really nothing else to salvage. That's really the last operation. So, anytime we do surgery, there's risks. In a surgery like that, where we're replacing the ball and socket joint, you can get infections, you can get fractures around the metal that we put in. So, those are some of the cons to a surgery of that nature. Again, next question is, can you use TENS unit on your shoulder? Yes. Yeah, we see a lot of that in the physical therapy office. They do like to use that. I've had some therapists say that they want to use it sparingly because people tend to become reliant on it for their shoulder pain. And so it's probably best used under the guidance of a physical therapist. Okay, the next question is an insurance question. Are there specific health plans that we work with? So, yes, good question. We do work with all Medicare, PPOs. As far as any HMO products, we work with the Regal Lakeside Group, Healthcare Partners, CareMore. I think that's it. But certainly, you can always call my office and we do all that to check and make sure that the benefits are correct for this office. Okay, now the questions are really they're good.
Oh yeah.
So here's a question. Somebody said they had a rotator cuff surgery 20 years ago. Now, when I exercise my shoulder, I hear a clicking noise. Should I still exercise? Well, I guess I would ask back, is there a pain with that click? Because oftentimes clicking is a little band of scar tissue or possibly that labrum, and clicking in and of itself isn't harmful. So yes, I would recommend in that case to continue to exercise it, strengthen the muscles around the shoulder. But it's easy to aggravate the shoulder with improper exercises. So you really want to make sure that you learn the proper technique with either a physical therapist or trainer, so that you're not doing more harm by having poor mechanics and then making more inflammation in the shoulder. But a click in and of itself, we don't get too worried about. The next question was, do you do PRP? So yes, I do PRP. Mostly do that for knee arthritis or chronic tendinitis of the elbow. Those are the ones that it's the most been shown to have the most benefit in the medical literature. PRP for shoulder problems, we do it, but it's not as well studied and it hasn't been proven to be as effective as these other areas. Certainly it's safe to do. For those who don't know what PRP means, it stands for platelet-rich plasma. And what that is we draw some blood from the arm, we spin it in a centrifuge to concentrate the plasma, which is the clear part of the blood, and then the platelets. The platelets are those cells that go to the site of injury first and tell the body to come heal the area. So they are the first cells that go there and create the clot if you get a cut, and then they signal the body to come heal. So basically what we do with PRP is we inject it to an area that's not healing or needs more blood flow, and we stimulate a healing response that way. So it's a natural anti-inflammatory and it helps promote healing. And the next question was, is the reverse stronger than the regular one. I wouldn't say that one's stronger than the other. There's certain indications to do one versus the other. The reverses are pretty durable. The thing with the regular shoulder replacement is that plastic socket can sometimes toggle or wear out, but the newer technology and designs have really fixed that problem. So they're both very durable at this stage with the newer technology. Does having osteoporosis put you at greater risk of shoulder or knee problems? So that's a very good question. Yeah, we do worry about folks with osteoporosis because you can get fractures, and the fractures can be very hard to treat in someone who has osteoporosis. Or you can also get, if the osteoporosis is so bad, you can have areas where the bone collapses just from normal day-to-day activity, walking or use. I've had some patients who have had rotator cuff tears with bad osteoporosis, and I go to try to fix the problem, and the bone is so soft it can't hold the anchors to do the repair. So then you're stuck with having to kind of figure out how best to treat it. And so yes, the osteoporosis does put you at a higher risk. So we always recommend checking with your primary care doctor to make sure that you have good calcium and vitamin D levels. Doing a DEXA scan, which is the bone density scan, should be done to see your risk for hip, spine, and wrist fractures. But yeah, good bone health is very important. So I'm glad you asked that question. What sort of the next question is, what sort of exercise should you do for a partial tear of the supraspinatus? So this is somebody who obviously knows their stuff. The supraspinatus is the top front rotator cuff tendon. It's the most common one that's injured. It's the one that lets you raise your arm up overhead like this. So without it, you're going to have pain and weakness with that movement. So the exercises that we recommend for folks are, we start with basic stretching, which includes some pendulums where you're going to let your arm hang in a circle. We do some assisted range of motion where you use the good arm to bring the arm up overhead, slide it across a table. Once you have range of motion back, that's pretty comfortable. Then you can start some bands. So we like these resistance bands, and you do forward lifts and rotation with these light resistance bands, and that seems to help. Then there's a question here about somebody got accepted to medical school. Congratulations. And yeah, I'd be happy to reach out.
Thank you.
Yeah, please, shoot me an email or talk offline and coordinate something. Yeah, I'm glad to have you. That's great.
That's awesome. Thank you, Dr. Morgan. Appreciate that.
So we have a couple more questions about the suggestions of stretches and exercises. So there's a website that I really like. Called Orthoinfoorg. Orthoinfo, all one word, .org, O-R-G. And that website is put together by the American Academy of Orthopedic Surgeons. So it's good, reliable information. It's not Dr. Google. There's somebody who can put anything out there. This is reliable stuff. So you go on there, it'll give you information about particular pain that you're having. You can go into kind of like what I did, where it explains all the different types of problems you could have and helps you to try to figure out what might be going on and ways to treat it. And in there is also physical therapy exercises. So there's a packet that I hand out to my patients specific to the shoulder, to the knee, to hip, ankle. They have all the different joints and an exercise program on there. So I really recommend that site. So about pain in the shoulder that wakes you up, is it better to apply heat or ice? So that's always a question I get from folks in the office. And in my opinion, I like ice for inflammation. So typically in the shoulder, you're going to have an inflammation of the rotator cuff or bursa. Ice is going to be best. If you're having a muscle spasm or tight muscle up in the neck area, heat is probably going to be better for that. So sometimes people are doing a little bit of both, just depending on where the pain is. But for muscle cramps and tight muscles, I recommend heat. For joint pains, I typically recommend ice. If you have pain reaching around to your back, should you keep doing it to get range of motion? So if you're having pain, you're trying to reach up behind your back and there's pain, you know, we want to get that inflammation down so there isn't that pain anymore before you continue to push the range of motion. So icing, taking the anti-inflammatories would be a first step before you try to push through for more range of motion. Because what you'll find with the shoulder, it's a very finicky joint. It doesn't really take a joke. So if you try to push it, it's gonna start to talk back to you. It's gonna be a little bit more painful. So we got to get that inflammation down before you can really do more of that stretching and get that motion back. Otherwise, if you just try to push through it, it's going to tend to be more painful and you'll take one step forward, 2 steps back. There's another question here about clicking when I rotate my neck. Don't worry. So clicking in the neck is different than clicking in the shoulder. Clicking in the neck could be arthritic related. But as long as you're not getting pain or numbness, tingling, traveling down the arm, probably nothing to worry about there. Pain coming from the wrist, shooting to the shoulder. So pain from the wrist coming up to the shoulder. So when you have pain that's radiating like that, that can sometimes be a nerve problem. You could have a pinched nerve at the wrist or up in the neck when you have pain radiating that much, that far up and down the arm. So typically with that type of radiating pain, you're going to start with some physical therapy exercises for your neck to see if that can alleviate it, and then talk to your doctor about possibly a short course of prednisone or steroid to reduce that inflammation around the neck nerves, and that can sometimes get rid of that shooting pain or that numbness or tingling. The next question is, why would you get burning sensation around the rotator cuff surgery? So I'm not quite sure if they mean around the surgical incision. Sometimes around the incisions, people get little scars. The scar and the nerves, the skin nerves get irritated and create little scar balls called a neuroma. And that can create sometimes some burning sensation or some numbness or tingling. Oftentimes that can be treated by physical therapy to do some desensitization, where they try to work the scar out, or you apply an anti-inflammatory cream, or sometimes we even inject that area with cortisone and numbing medicine to try to decrease that nerve irritation. Can lifting heavy bags do damage to the upper arm or shoulder? This activity has done something to my left shoulder, so I cannot do push-ups for more than a few minutes. I also feel pain when I lift my jacket, arm, etc. Yeah, so I see a lot of folks in my office who've come in, you know, they're reaching out and they're lifting something heavy up out in front of them. That's about the worst thing you can do for your rotator cuff. You really want to try your best to lift close to the body using your biceps, as opposed to lifting out with the arm out extended like that, because that really puts a lot of strain on the rotator cuff and can cause damage. So it sounds like if you're having pain to the point where you can't do push-ups, or when even you just try to put on a jacket or lift your arm, you may have some rotator cuff tendinitis or maybe a small tear. Suddenly, if that's been going on for a long time and hasn't gotten better with some of the exercises or anti-inflammatories or ice, then it would be time to get that looked at. And then the last question I have here is massage helpful? A lot of patients do like the massage. Especially for any sore muscles up and around the neck area and in the back around the shoulder blade, tends to be pretty effective. If your pain is that classic kind of on the side of the arm rotator cuff tear or tendinitis pain, it's not really much they can do to massage that out. But if there's pain in the neck or around the shoulder blade in the back, that can be helpful. Oh, we have one more question pop up here. Is stem cell therapy available, or is PRP stem cells? So yeah, that's where it gets a little confusing. PRP is not technically stem cells, although sometimes it will be promoted and marketed as such. You have a few stem cells floating around in your bloodstream, but not enough to be a high enough concentration to really consider it a stem cell treatment, in my opinion. typically when we're talking about stem cells, so these are the cells that can become any type of cell in the body. And where you have the highest concentration of those are in your bone marrow and in your fat, actually. So there are some folks who will harvest bone marrow and concentrate that, and you have a much higher percentage of stem cells in that than you do in just your peripheral blood. Same thing in the fat. Sometimes you can harvest some of that and you spin that and you can get some stem cells out of that. And so there are folks in town who are doing those. I don't do those in the office. I do PRP because it's an easy blood draw, minimally invasive, no harm to the patient. I will do some of the bone marrow draws and injections in the operating room when I'm using it to augment healing, especially for some of the knee cartilage procedures that I do. And when we're using these donor grafts and things, we'll use the bone marrow stem cells to help augment that. All right. Looks like the last question here, acupuncture better than PT? You know, I find that physical therapy is probably going to be better. Acupuncture certainly can have a role as a adjunctive treatment. I wouldn't consider it the only way to treat the shoulder. I think it could be done in combination with some physical therapy, but certainly can be a good pain reliever in that regard. All right, well, everybody. Well, thank you so much for all your questions and for your attention today. It's really been nice to be able to talk shoulders. That's my thing.
Thank you so much. Thank
Yeah.
you.
And please reach out. If you have questions, concerns. I gave out my office information there, and then the website was posted by Kathy on the chat there. So check that out. It's a good resource for folks. And
I just want to mention, I don't, with that website, somebody had asked if they had to log in or anything. No, they don't.
No.
It's there.
No.
It is. There it is again.
It's just for public information. But it's just, put together by the Academy of Orthopedic Surgeons. So it's going to be, appropriate information, facts, not opinions, things like that. So it's a good site.
Exactly. Well, thank you so much, Doctor. That was really good. And I
Sure.
know that you probably spoke to quite a few of our members here in this talk. So appreciate it very much. And for somebody that hasn't done this before or Zoom before, you were a pro. You would have never known that.
I have a question because somehow I didn't get my chat in correctly.
Oh, okay.
Can you hear me?
Yes.
Do you work on broken clavicles? I was hit by a car in 2017 and I have a broken clavicle.
Yep, I definitely do. That's an interest of mine. Yeah, we take care of fractures about the clavicle and shoulder. Yeah.
But it's been several years since it happened.
Yeah, if it's still painful, that means that maybe the bone didn't heal all the way and it just healed with some scar tissue. Sometimes if the bones breaks and they aren't close enough, the bone cells can't talk to mend. So then what happens is scar tissue forms between the bones and there's enough motion there still where it can be persistently painful. So, if that's the case, yeah, we should get an x-ray, get it looked at, see if there's anything that can be done to help.
Thank you.